All right, we are going to look at Chapter 21, Part B, and we're going to do Part B in individual segments. So we'll start with the mechanics of breathing. Breathing is pulmonary ventilation. It has two steps, inspiration and expiration. During inspiration, gases flow into the lungs. This is breathing in. During expiration, gases flow out of the lungs. This is breathing out. There's different pressure relationships we want to acknowledge. So we'll start with one of the pressures that is involved in the respiratory system and why it works. That is atmospheric pressure. This is the pressure exerted by air that surrounds your body, and at sea level, atmospheric pressure is 760 millimeters of mercury. But we're going to set atmospheric pressure to 0. That way we can compare other pressures to it. And a negative pressure is going to be less than atmospheric pressure. A positive pressure is going to be greater or more than atmospheric pressure, and a 0 respiratory pressure will be equal to atmospheric pressure. This is important to simplify the processes of inspiration and expiration when we look at the relationship between pressure and volume in those processes. Negative pressures are going to be pulling pressures, and they are going to pull air towards themselves. Positive pressures are going to be pushing pressures. And so wherever there's a pushing pressure, we're going to have airflow away from that location. Another pressure we want to look at is intrapulmonary pressure. Intrapulmonary pressure is the air in the lungs, and that pressure exerted there in the alveoli. It's also sometimes called the intraalveolar pressure, but we'll stick with intrapulmonary pressure. It's going to fluctuate with breathing, so it'll fluctuate as you breathe in and out. The alveoli will inflate as you breathe in, and they will deflate as you breathe out. There are going to be moments in time during inspiration and expiration where intrapulmonary pressure will equalize with atmospheric pressure. Another pressure is intrapleural pressure. Intrapleural pressure is the pressure in the pleural cavity between the parietal and visceral pleura. It's always a negative pressure, so it's going to be less than atmospheric and less than intrapulmonary pressure. It needs to be negative because it's going to hold the parietal and visceral pleura together, and since the parietal pleura is going to be attached to the thoracic wall, and the visceral pleura is attached to the lungs, essentially what the intrapleural pressure does by being negative is it superglues your lungs to your thoracic cage. So whatever happens to your thoracic cage, like they expand, that means your lungs will also expand. Also, this pressure being negative means there's no air in this intrapleural space. There's no air between the parietal and visceral pleura, just fluid. If fluid began to accumulate or air got into this space, then it would become a more positive pressure, and that could cause a lung collapse. There's a couple of forces that are promoting the intrapleural pressure being negative. There's two inward forces that are trying to make the lungs collapse. The lungs have a lot of elastic tissue on them. They want to recoil. They want to be as small as possible. And because of this elasticity, they're always trying to become smaller, to move away from the thoracic cage. But there's also surface tension in the alveolar fluid. So not only do you have this high elasticity of the lung tissue itself, with all of its elastic fibers making up its stroma, you have the air spaces themselves trying to become as small as possible, trying to deflate, especially during expiration. And these two inward forces are promoting lung collapse. So if it wasn't for one outward force, which is quite strong, then we would actually see that intrapleural pressure would be positive because the lungs would collapse. So we do rely on this one outward force, which is the compliance or elasticity of the chest wall, to be able to pull the thorax outward. So because of the physiology of the pleura, because of there being only fluid between those two layers, and because of these three forces fighting to either make the lungs smaller or allow them to expand, we have created an area where we have always a negative pressure, but it works well for the processes of inspiration and expiration. So that negative intrapleural pressure is always going to be affected by these opposing forces, but we're maintaining a strong adhesive force between those two pleura, so we're maintaining the physiology and the anatomy of the respiratory system, and this is why it works and why inspiration and expiration are also based on physics. Transpulmonary pressure is a pressure that keeps the lung spaces open. It's the difference between intrapulmonary pressure and intrapleural pressure. And this is the pressure that can demonstrate that intrapleural pressure is negative. We can look here at this image and see where some of these pressures would be located. So intrapulmonary pressure would be located in the lungs. Intrapleural pressure, always negative, located between the lungs and the the thoracic wall. And then you also have atmospheric pressure, which is located outside of the body. So they've even set atmospheric pressure to 0. So if inside the lungs there was a negative pressure, air would flow from high to low pressure. If inside the lungs there was a positive pressure, air would flow from high to low pressure. So the negative and positive pressures versus atmospheric pressure give you a lot of information for which direction air is going to flow, in or out of the lungs. A pneumothorax can occur if the parietal or visceral pleura are ruptured. Here they've given you 2 examples for rupture, a spontaneous visceral pleura rupture or a parietal pleura rupture from a knife wound. Both would cause air to get into that intrapleural space, and that would cause a positive pressure that would lead to lung collapse. Lung collapse here is called a pneumothorax. Lungs can also collapse because of plugged bronchioles. Again, bronchioles are small tubes, and they can be plugged or clogged because of inflammation or mucus secretion. This causes collapse of the alveoli. So that's going to disrupt one of the 3 forces, and that's going to make the force that is promoting alveolar collapse much stronger than it would normally be, and that's going to outweigh the other 2. We'll look closer now at pulmonary ventilation. So again, pulmonary ventilation is breathing. You breathe in and out. Breathing in is inspiration. Breathing out is expiration. These are both mechanical processes that depend on volume and pressure changes, and these volume and pressure changes are related and can be explained with Boyle's law. Boyle's law says that whatever happens to pressure, the opposite happens to volume, or here we see the definition relationship between pressure and volume of a gas. So what we'll see is if pressure increases, volume decreases. So if pressure in the lungs increases, that means that volume must have decreased in the lungs, and vice versa. The steps of inspiration are an active process. Active meaning they need ATP to occur. The reason it's an active process is muscles contract. The muscles that contract are called the inspiratory muscles, which include the diaphragm and the external intercostals. The diaphragm flattens when it contracts, and the external intercostal muscles lift or move the rib cage outwards. And this will create more volume in the thoracic cavity. So the steps of inspiration, the inspiratory muscles contract. That increases thoracic cavity volume. If volume increases, then pressure decreases. I know that because of Boyle's law. And then I also know that because of intrapleural pressure, the lungs are superglued to the thoracic wall. So if the thoracic cage moves outward, the lungs are also going to move outward or be stretched. So that will increase not only thoracic cavity volume, but also intrapulmonary volume. And if intrapulmonary volume increases, again, pressure decreases. So compared to atmospheric pressure, we'll have a negative pressure now inside the lungs. And negative pressures pull, and that's going to pull air into the lungs. The opposite is expiration. During expiration, the inspiratory muscles relax. This will be a passive process. When the inspiratory muscles relax, they lower the rib cage and the diaphragm resumes its domed shape. So this will decrease thoracic cavity volume. That means it'll also decrease lung volume. So intrapulmonary volume decreases. And the main reason that intrapulmonary volume decreases so much during this process is because of the elastic tissue stroma, or elastic tissue of the lungs. So elastic lung recoil, or elastic recoil of the lungs, is a big step of expiration. Without this elastic tissue, yes, the lungs would decrease in volume, but not so much to have such a profound effect on expiration. So if we have a decrease in thoracic cavity volume, we have a decrease in lung volume because of elastic recoil of the lungs. We'll also have an increase in intrapulmonary pressure. So an increase in intrapulmonary pressure is going to make the pressure in the lungs positive compared to atmospheric pressure. And a positive pressure pushes, so this will push air out of the lungs. So air or gases flow out of the lungs. So I used all the terminology there so we could talk about inspiration and expiration. I'm just going to simplify it very quickly. So during inspiration, the thoracic cavity volume increases, so the lung volume increases. If volume increases in the respiratory system, pressure decreases. The negative pressure in the lungs pulls air into the lungs, and it all began with the inspiratory muscles contracting. For expiration, the inspiratory muscles relax. That decreases thoracic cavity volume, which decreases lung volume because of the elastic recoil of the lungs. If we decrease lung volume, that's going to increase pressure. The increased pressure in the lungs is going to be a positive pressure that pushes air out of the lungs. Again, the inspiratory muscles are the diaphragm and the external intercostals. During inspiration, they contract, which requires ATP, so inspiration is an active process always. During expiration, the inspiratory muscles relax, so that's a passive process. Forced expiration, that's an active process, but regular expiration, that is always a passive process, does not require energy. For inspiration, we're going to see that, again, intrapulmonary pressure is less than atmospheric. That will pull air into the lungs. Then we'll have a moment where intrapulmonary pressure is equal to atmospheric pressure, and then we'll enter into expiration where that pressure starts to build and become more positive. A forced inspiration is also active, just like regular inspiration, but during forced inspiration, you use more than just the inspiratory muscles. You use more than just the diaphragm and the external intercostals. Other accessory muscles that may be involved in forced inspiration are the scalenes, sternocleidomastoid, and pectoralis minor, and then sometimes also the rector spinae muscles of the back. These accessory muscles will increase the thoracic cage size and therefore the lung volume even more than during a regular inspiration. This would be common or could occur during just regular exercise, especially if it's vigorous, or in someone who has a respiratory disorder, such as COPD. So quiet expiration is also known as normal expiration. Again, passive, begins when those inspiratory muscles relax. But there is forced expiration, that's an active process, where you use the transverse abdominal muscles, as well as the obliques, and even the internal intercostal muscles to force even more air out of the lungs. In this image, we can see that during inspiration, we have a drop in pressure compared to atmospheric pressure that pulls air into the lungs. And during expiration, we have an increase in intrapulmonary pressure compared to atmospheric pressure, which pushes air out of the lungs. And there's also some non-respiratory air movements, and these you're probably familiar with, things like coughing, sneezing, crying, laughing, hiccups, yawns. A lot of them are reflex actions. Some we don't know exactly why they occur. They're not necessarily voluntary, although some are. Hiccuping, for example, is usually an involuntary action, but they could or may modify normal respiratory rhythm. They can get in the way of normal inspiration and expiration. So these processes can also move air, but they're not a part of normal pulmonary ventilation. And again, that's because pulmonary ventilation includes inspiration and expiration. And we'll stop there and we'll pick up later with the physical factors influencing pulmonary ventilation.